Good morning, dear Bcmch family. Welcome to this week's quest. And we have a very intriguing topic today, and we are all gathered here eagerly, waiting to know what lies behind that title. So before we start with our proceedings, may I request our dear Thomas Sachin to start with a word of prayer.
We'll pray. പിതാവിനും പുത്രനും പരിശുദ്ധനും സ്തുതി ആദ്യമോ നന്നേക്കും തന്നെ ആമേൻ. പരിശുദ്ധനും നിത്യനുമായ ഞങ്ങളുടെ സ്വർഗസ്ഥ പിതാവാം ദൈവമേ, അനദർ തേഴ്സ്ഡേ, അടുത്ത ഒരു പുതിയ വ്യാഴാഴ്ച ഞങ്ങൾക്ക് വീണ്ടും തന്നുവല്ലോ. അതിലുപരിയായി ഈ മെയ് മാസത്തിൻ്റെ 1-ാമത്തെ വ്യാഴാഴ്ച, 2-ാമത്തെ ദിവസം ഞങ്ങൾക്ക് അവിടുത്തെ നാമത്തിൽ കൂടി പുതിയ കാര്യങ്ങൾ കേൾക്കുവാൻ, പഠിക്കുവാൻ, അതിനെപ്പറ്റി ചിന്തിക്കുവാൻ, അത് ഭാവിയിൽ ഞങ്ങളുടെ തലമുറയ്ക്കും വരുന്ന തലമുറയ്ക്കും ഒരനുഗ്രഹമാക്കി തീരുവാൻ ഇതുപോലെ ഈ വ്യാഴാഴ്ച ദിവസം ഞങ്ങൾക്ക് വന്നുകൂടുവാൻ തയ്യാറാക്കിയ ഈ ക്വസ്റ്റിനായി നന്ദി. ഇന്നും അതിന് നേതൃത്വം കൊടുക്കുന്നതായിട്ടുള്ള 3 ഡോക്ടേഴ്സിനെയും മറ്റെല്ലാ കാര്യങ്ങളും അവിടുത്തെ കാര്യങ്ങളിലേക്ക് ഏൽപ്പിക്കുന്നു. വന്നിരിക്കുന്നവരെ ഓരോരുത്തരെയും അനുഗ്രഹിക്കണമേ. പ്രാർത്ഥന സ്തോത്രം യേശു ക്രിസ്തുവിൻ്റെ വലിയൊരു നാമത്തിൽ തന്നെ. ആമേൻ. പ്ലീസ് ബി സീറ്റഡ്.
Dynamism takes a tip or two from her. She's out here to moderate this session. None other than our dynamic Assistant Professor of General Medicine and Assistant Director, Dr. Thampi. Over to her as she moderates this session for us.
Good morning, everyone. So welcome to another exciting session of Quest. So this week's Quest is going to be conducted by our renowned Department of Nephrology, who is known for their clinical expertise and patient care. And they'll be giving us a case discussion and a case series revealing the disguised villains, Hairstraightena Bilimbi. I hope they are excited regarding the name itself. So most of the time, an acute nephropathy always presents a formidable challenge to the treating physician because of the varied etiology and the overlapping clinical presentations. Most of the time, young patients, when they come to us, we have to decide whether it is an acute cause or is it is a chronic cause, and whether it is recoverable, and whether there are any, long-term complications, and the prognosis in most of these cases, what it is going to be. So, to present the first case, I invite consultant nephrologist, Dr. Sneha Joy. She has completed her MBBS and MD in General Medicine from CMC Ludhiana, and she did a DM in Nephrology from Pushpagiri Institute of Medical Sciences. And she has joined us in the Department of Nephrology and has been with us since almost 1 year now. So she is going to present a case of a young lady, a 27-year-old lady, who had actually gone to multiple hospitals with the same ailment and ultimately landed up in Believers Church Medical College Hospital in her OPD, and she diagnosed it in her OPD and evaluated the case. So let's hear from Dr. Sneha on her journey on diagnosing this patient.
Good morning, and let's go ahead with the case without much ado. So, this is, we have so many patients who come to the OPD every day, and we might think, oh, everything is a CKD, or it's just another creatinine, another dialysis patient. But amidst so many patients, we often find one exciting patient. And unless we look for it, we are going to think that this is another CKD which was missed. And this is one such moment we had. So this is Mrs. D, a 26-year young lady who came with complaints of generalized headache since March 2024. Very short history. She has been known to have hypothyroidism, migraine for which she takes only Cybelium, no NSAIDs, and PCOD. She was evaluated for PCOD 2-3 years back, and at that time she said everything was normal. So she was working in Chennai, and when she went to a local hospital with a high headache, she was told that she had a high BP. She was started on some medications for the same, and she was also noted to have elevated creatinine. She doesn't know the value at that time. But hearing this, she came to Kerala for further evaluation, and first she went to a hospital near her house, and with the same history, they evaluated her. And this was on 19th March. So on 10th March was when she had the headache. On 19th March, she went to the local hospital and HB was 11, urine routine was normal, creatinine was 2 and they said, we cannot manage it, you go to the next place. That's when they went to Government Medical College. At that time, they saw all the reports there and they got an ultrasound also done. That showed normal size kidneys with poorly maintained CMD. So seeing that cortically medullary differentiation was poorly maintained, they said it's most probably CKD, but we can do a biopsy, but most probably it's not going to recover. And they thought they'll get another opinion. And they went to another hospital in Tiruvalla. That was on 24th March. Again evaluated. That time creatinine is 1.7. Urine has got some proteinuria now. It has got albumin of 2+, but no active sediments there. Then finally on 28th of March, she presented to our hospital. And we'll just go through the outside labs before. So first hospital, local hospital, HB11, ESR was 8, creatinine was 2, urine routine shows no albumin, 2 to 3 RBCs are there, sodium potassium is normal, counts are normal. Second hospital, they got only the ultrasound done, that is showing normal size kidneys with increased echogenicity, poorly maintained CMD, no calculus, no obstruction. Third hospital, normal HB, creatinine of 1.9, urine routine shows 2+ albumin now, and some RBCs and WBCs are here. LFT is normal, HbA1c is 5.2. So we have a young patient, no significant comorbidities that would lead to a CKD, new onset hypertension along with renal dysfunction. And lab-wise, renal dysfunction, subnephrotic proteinuria, plus some microscopic hematuria, and ultrasound which is showing echogenic kidneys with partially maintained CMD. So we said we'll again evaluate. We have got so many labs which are showing so many different values. We'll just do ours again. And we have a creatinine of 1.9, total protein of 6.5 and albumin of 3.7. Uric acid is little high, 10.4. We got a rapidly progressive renal failure panel. So that is ANA profile, complement C3, PANCA, CANCA, anti-GBM antibody. All those were negative. That is because we had those RBCs in the urine. We had to look for vasculitis, which can occur in the young also and in the old age, but more in the old age. And our urine routine that showed albumin of 3+, RBCs 3 to 4 and pus cells of 2 to 3. So a few active sediments, few RBCs. We did an ultrasound screening with our own USG machine and we saw that the kidneys were normal size, slightly raised echogenicity. CMT was partially maintained but not too bad. So we told her, because she's a young lady, it will be better to do a biopsy. So when we get such a patient, we are often confused. Is this an AKI or is this a CKD? So some pointers towards AKI would be that she's young, she has not had any history so far, and her HB is well maintained, and otherwise also physically she's well maintained. She's a normal looking patient, nothing CKD features in her. And something that points towards CKD is the fact that she doesn't have any symptoms. So something that happens acutely, sometimes they often have symptoms, uremic symptoms or edema or something. So no symptoms at all other than the headache. And the ultrasound which is showing the partially maintained CMD is also pointing towards a chronicity. Other than that, once we know that this is either an AKI or CKD, we also have to see which compartment of the kidney is being affected. Is it the tubulointerstitium? Is it an obstruction, glomerulus, vascular? So we have to see, is it pre-renal? So in this young age, if it is pre-renal, if she had taken enough water, it would have recovered by now. It wouldn't stay for 15 days. And she doesn't have any symptoms again, and no cause why she should have a pre-renal. Is it post-renal? Is it an obstruction? Is it a urethral stricture? Is it CS cervix? But she's too young for that, no symptoms like that. So unlikely to be post-renal. Is it a glomerular compartment which is affected? So we have to see, is there a glomerular proteinuria? There is proteinuria, but it is not causing a hypoalbuminemia. And if we had done an RBC for any dysmorphic RBCs, we would have probably seen that there are no or yes dysmorphic RBCs based on whether it's a glomerular compartment. The next comes a tubulointerstitium. So tubulointerstitium is likely because she doesn't have much edema. She has very low proteinuria. There are some pus cells in the urine. So all that points to a possible tubulointerstitial compartment. And it could be vascular. But vascular is also highly unlikely in her place. There's no renal artery stenosis. There's no atherosclerosis at this age. And even if it's a renal vein thrombosis, she would have had hematuria or severe pain. So nothing to point to vascular. So we are probably looking at either an acute tubulointerstitial disease or a chronic tubulointerstitial nephritis, which is probably unnoticed over so many years, and she never got it evaluated. So we said, anyway, we'll go ahead with a biopsy because that is the only way we can find out what it actually is. So as I was talking to her, she said she's working as a manager in Tony and Guy Saloon in Chennai. And she had this nice straight hair. And I said, oh, this is a very nice straight hair. Where do you get it done? She said, oh, we do this Botox Brazilian straightening. So I said, this is on 28th March. So I said, on 20th March, we had a paper which came out in NGDM which said that kidney injury is there with hair straightening products containing glyoxylic acid. So I said, I have not seen any patient. I've got my hair straightened and nothing happened. And so many of my friends got it. So this is probably something that happened in that country, not us. But she is a manager and she knows what she's doing. So she uses the products for others and she used it on herself. And she said, no, this is what we use. This is Brazilian hair Botox therapy and it contains glyoxylic acid. So I said, wow, that is a possibility. And we found it the day before the biopsy. And I said, that is an interesting possibility, but we'll see. We'll still, if it is good, if it is glyoxylic acid, we have a good chance of recovery. There's no chronicity. But we have to keep our minds open and probably it is a CTID. We'll anyway go ahead with the biopsy. So that is when we went ahead with the biopsy on 5th of April.
Dr. Anita Wilson from the Department of Pathology will be discussing on the renal biopsy slides.
A very warm good morning to one and all. I am Dr. Anita, Senior Resident, Department of Pathology. I'll be discussing the renal biopsy finding of this super interesting case. So before coming to the case proper, let me just quickly mention our general approach to the medical renal biopsies. The first part of the renal tissue that we study is the glomerulus, followed by the tubules, the interstitium, and the blood vessels. This would help us to subcategorize the primary pathology into a glomerular, a tubulointerstitial, or a vascular pathology. So the picture here shows a normal glomerulus with the Bowman's capsule, the supporting cells called the mesangial cells, and the intervening capillary networks. So these are the tubules. If you can make out, the tubules on the left are more eosinophilic and more irregular, which are the proximal convoluted tubules, and those here are round with cuboidal epithelial lining, which are the distal convoluted tubules. The tubules usually show a back-to-back arrangement with little intervening space in between. This intervening space is what we call the interstitium, and the interstitium gets expanded when you have a fibrosis or an edema. And the fourth compartment that we study is the blood vessels, which may show pathologies like an arteriolosclerosis or a vasculitis. So coming to our case, we received two linear cores of tissue. One was a muscle fragment and the other was a renal cortical tissue. So there were 4 glomeruli in the best visualized section. This is a representative glomeruli which showed no significant pathology. So the tubule showed infiltration of inflammatory cells into the tubular epithelium. If you can make out, the neutrophils are infiltrating the tubular epithelium as well as the tubular lumina. There was some loss of the tubular epithelial cells with sloughing of these cells into the lumen and flattening of the tubular epithelium. So there was some form of tubular injury which we usually call as tubulitis. So this is another area showing the sloughing of the epithelial cells as well as neutrophilic infiltration into the tubules. As you can make out, the back-to-back arrangement of the tubules have been lost and the interstitial space is expanded due to edema and infiltration by inflammatory cells, predominantly the neutrophils. So basically, this is an acute tubulointerstitial pathology. So on a closer look into the tubules, we could make out these pale translucent crystals within the tubular lumina. So a higher magnification of the same. So we proceeded to study these tubules under the polarizer microscope and these were positively birefringent. So these positive birefringent crystals were distributed throughout the tubular interstitium in different parts of the renal biopsy. We also did a direct immunofluorescence which did not show any immune complex deposit with our routine IF markers. So the immunofluorescence was also negative. So our diagnosis at this point is a tubulointerstitial nephritis with crystal deposition, which we call a crystalline nephropathy. The differential diagnosis includes drug-induced nephropathies. Drugs like indinavir, acyclovir, triamterene, etc. are known to cause drug-induced crystalline nephropathies. Dysproteinemia-related nephropathies, where you have an increased monoclonal protein deposition, as in multiple myeloma, which can cause deposition within the tubules. Inherited disorders like Glavy syndrome, Den syndrome, primary hyperoxaluria can cause crystal deposition in the kidneys. And fourth and most common is the calcium-associated crystal nephropathy, which include the calcium oxalate and calcium phosphate crystals. So the diagnosis will depend on the clinical correlation coupled with the light microscopy, polarizer, special stain, and immunofluorescence findings. This correlating clinically with the light microscopy, polarizer, and immunofluorescence finding, we signed out the final report as acute tubulointerstitial nephritis with calcium oxalate deposition consistent with oxalate nephropathy. Thank you. Over to you, ma'am.
We got a diagnosis. So it was an oxalate nephropathy. So how does this glyoxylic acid cause oxalate nephropathy or AKI? So we know in the pathway in the liver, this glyoxylate in the presence of lactate dehydrogenase is converted to oxalate, and that is how it causes oxalate nephropathy. So this case, I will just go through the two cases that the reports that was there. So this NEJM case, it talked about a 26-year-old Tunisian woman. She had 3 consecutive episodes of AKI in 2020, 21 and 22, each after a hair straightening treatment. And the cream that was used there had 10% glyoxylic acid in the cream. So seeing this, they went ahead and did an animal study. They used 10 rats. 5 were given 10 grams of the cream daily for 2 days, and the other 5 was given liquid paraffin. And they studied the urine of the rat, and they found the calcium oxalate monohydrate crystals in the rats that received the cream with the glyoxylic acid. The creatinine on the day following the application was much higher in the rats which received the product. They did a CT of the rats, and the rat kidney with the liquid paraffin showed a normal CT in the 3D reconstruction. And in the one that received the hair straightening cream, you have these hyperdense calcium deposits which are seen throughout the kidney. So they proved that it was glyoxylic acid. Similar to this, there is actually one more publication. This came in July 2023, and this was mainly from many hospitals in Israel. So 26 patients from 14 medical centers in Israel. And they all reported with severe AKI to the hospital and then gave a history of having used hair straightening products. Majority of them were containing glycolic acid derivatives. 7 out of these 26 patients underwent a biopsy, out of which 6 had intratubular calcium oxalate deposition, and there was acute tubular injury in all. And few of these patients even required dialysis. So other than that, there were no similar case reports. So we often think that a lot of things are probably harmless, but too much of anything is bad, and some things even too little is bad, I guess. So we have vegetables like spinach, kale, beets. We have fruits like star fruit and bilimbi, nuts, peanuts, cashew nut, even almonds, black tea, iced tea, even excessive use of vitamin C. All these can cause oxalate nephropathy. So this is a review article on oxalate nephropathy. This was published in February 2022, and they said that peanuts up to 100 to 200, 250 grams for 2 to 3 months. Cashew nuts around 1 kg per week, so 150 grams per day for 4 months. Almonds up to 50 to 100 grams. Rhubarb, mushroom powder. We do get these shroom teas nowadays here. We have black iced tea, 16 8-ounce glasses per day. We even had a few cases in CMC Ludhiana where in the summer they drank too much of iced tea and came with oxalate nephropathy. And those who are into juicing and gymming, they drink all their vegetables as a juice. They can also go into but this doesn't happen to everyone, probably because of the hydration level. If you hydrate yourself really well with it, and based on the dose in which you take, you may not develop a nephropathy. That's why it's so rare. And probably a lot of it is going missed also because not everyone checks their creatinine or urine after taking all these. So this, other than this, oxalate nephropathy, it can be, so we said it can be an increased dietary oxalate, it can be a decreased intestinal oxalate degradation by microbes, because if there are some bacteria that decompose the oxalate in the food we eat, and excessive antibiotics can lead to loss of gut microbiota. There can be increased intestinal obstructions due to some surgeries like gastric bypass surgeries. There can be endogenous oxalate production in patients with primary hyperoxaluria. And in all these cases, if you measure a 24-hour urine oxalate level, it might be high, and this can lead to oxalate nephropathy. So what happened to our patient? So our patient, we saw this and we said you have to hydrate really well. So we asked her to take 3 to 3.5 liters of water per day. So what hydration does, it lowers the urinary calcium oxalate supersaturation. So it prevents the crystal formation. Then citrate is another method can be used because it will inhibit the calcium oxalate crystallization, but not very proven, but it's something that we can try. And in our patient, though it is not in the usual, we gave a low dose of steroids because there was so much of tubular interstitial inflammation. So a low dose of steroids also we have given. And she is yet to come. So we have a few more tales, and Dr. Rajesh sir will be sharing it with us.
So I think we don't have any cases from India yet regarding on hair straightening products causing an AKI. This may be one of the first cases from India. So far, 26 cases reported from Israel. That was a retrospective study from 2019 to 2022. And a recent case was published in NEGM from Tunisian women. And a recent study in France. I think this may be the first case from India to be reported. I think most of the cases has been after 2019. That is when the formaldehyde-free hair straightening products came into use. And if you go through the cases, I think most of these women have recovered from the AKI. Only 2 or 3 of them had needed to go in for dialysis. I think further studies needs to be made to shed light on what are the long-term effects of hair straightening products. And it is not just a hair straightening products, but also hair straightening shampoos and also styling lotions, which actually contain glyoxylic acid, which can ultimately lead into an oxalate nephropathy. So I think we need to comment on Dr. Sneha's discernment to identify the instigator in this case, because even though oxalate nephropathy has been there's been increased recognition of oxalate nephropathy. Most of the time, we miss out the diagnosis because of missing it in the clinical history taking, or, patient does not give us the details regarding that. So I think big applause to Dr. Sneha for finding it out. Moving on, we have the next case series by our dynamic head of the Department of Nephrology, Dr. Rajesh Joseph. I don't think he needs any introduction. So over to you, sir.
Thank you, Dr. Annie. Respected GC sir, professors here, senior consultants, my colleagues, friends, students, and all others here in the amphitheater. Revealing the disguised villains, the first presentation by Dr. Sneha would have sent definitely a kind of shudder. Probably Annie Thampi with that beautiful straight hair would be also thinking, should I have gone for it again, or can I go for it again? It's naturally straight. Oh wow, that's different. Okay, so going ahead with revealing the disguised villains, I have a few cases. This is a prototype. This case 1 is a prototype of 3 other cases we had in our department. We have a 48-year-old gentleman. You can imagine the dreaded time of COVID lockdown. I think we don't like to recollect it once again, all those years at home. This man was working as a salesman in a jewelry shop. He presented to us with nausea, vomiting, and decreased output of 3 days duration. So this history-wise, it's something acute which has happened because the other is doing good. And when we evaluated, we found that his hemoglobin was 14.5. That it was not anemic. So something which is probably acute. But his urea was quite high, 230, with a creatinine of 13.2. Urine showed pus cells which was 8 to 12. Albumin was just 1 plus and RBCs 1 to 2. When you see a pus cells like this, okay, there is a worry like, could it be again urinary infection? maybe patient can present with nausea, vomiting, and then probably a decreased output could be patient developing papillary necrosis, ureteric obstruction, and so on. When we did an ultrasound, which showed bilateral bulky kidneys. So when we looked into the counts, we found that it was normal. CRP was also normal. And we took a history of that. We didn't find any nephrotoxic agents. So lockdown, 48-year-old gentleman presenting with severe renal failure. The second case is a 12-year-old boy. He presented with history of blood in urine, just a 12-year-old chap. And his renal functions was found to be normal. But when an ultrasound was done, there was multiple small stones in both the kidneys. So it was around less than 3 mm. So multiple small stones. The third case is again a prototype of 2 more cases we had. A 64-year-old male who had a history of dyslipidemia and diabetes of 3 years duration. He had done a regular health checkup package just prior to developing this illness, and we found that he had very high cholesterol and a normal renal function. He presented with bilateral flank pain and vomiting of 5 days duration. And we looked at the investigations, we found urea was 256 with a creatinine of 9.2. Albumin was trace with a pulse of 6 to 8, and he had oxalate crystals present in his urine. Ultrasound showed bilateral bulky kidneys, normal counts, and CRP was normal. So these are the 3 case scenarios we have. And when you look at these features, there is a rocking chair, a clock ticking, and oh my God, who could be the villain be here? That was worrying us during this time. So let me come to my presentation proper, culinary misadventure. Many of us would have seen this tree with this beautiful fruit. Let me go into some more detail about this particular fruit. This fruit is known here in the state of Kerala as Irumban or Chimopuli. And its scientific name is Avaroa Bilimbi. Avaroa Bilimbi. And this belongs to the family Oxalidaceae. It's widely cultivated in tropical countries and grows to a height of 5 to 10 meters. This fruit has around 5 longitudinal lobes, and they are in clusters. They form in clusters, and it looks very beautiful because this tree is full of this fruit. Even the root has these fruits growing. This fruit actually is very sour. If you have taken it, you find it's very sour. Now, Avaroa Bilimbi is a delicacy in various parts of the world, especially in Southeast Asia. And with this, what do they do is they make homemade vinegar, pickle, compote when cooked with spices and sugar, jam, jellies, wine, and so on. And in Kerala, it has been used as a traditional remedy for treatment of multiple diseases like dyslipidemia. This is our patient actually would have had taken this because he had high cholesterol, hypertension, anti-cancer, anti-diabetic, wound healing, anti-inflammatory. And the thing is, freshly made concentrated juice has a very high oxalate content. So juices definitely has very high content. We should be careful. The kidney is a primary organ through which this oxalate is excreted, and deposition of this oxalate crystals happens in the renal tubules. It's already been presented by the pathology department. Under polarized light, it gives a bright birefringence. And when you look under light microscopy, it shows an envelope-shaped crystals. Normal 24 hours urinary excretion of oxalate is less than 50 milligram. Now, Irumbambuli, if you look at the oxalate content, it's quite high compared to other fruits. This has been analyzed by spectrophotometry method at Amrita, Kochi. When we actually, years back, we published this paper, I could also be an author to this case series we had, and the oxalate content in this fruit was analyzed at that point of time. It's quite high, that is 25.1 per 100 gram. Now, this was the biopsy of one of our patients when we published this article, which was around in 2012-13. So the renal tubules showed acute tubular necrosis. Now, you can see it in the bold arrow much below the slide. The lowest part, you can see the bold arrow, which shows the necrosis, the tubules with the necrotic material within. And if you go slightly higher up, there is a thin arrow. It's difficult to identify. You can see the intratubular fractured cast of oxalate. Let me go through some of the basic pathogenesis which we see is oxalic acid has got a direct toxic effect on the renal tubules and the interstitium. It facilitates, what happens is when you take fluid or juice or food which contains high oxalate, they form crystals which are endocytized by the renal epithelial cells, and this will promote a proliferative response. And they also stimulate specific genes in the renal tubular cells, including the connective tissue growth factor gene, leading to interstitial fibrosis. ARF can occur because these crystals can obstruct the tubules and cause renal failure. So let's go back to our patient again. First case is a 48-year-old gentleman. He was working as a salesman in a gold shop. What was actually a good habit he had is he used to have alcohol every day at night after his work. That was his relaxation mode. And what happened was, lockdown time, no way to get alcohol. So what he did was, he learned that Irumbambuli could be made into a alcohol. So, and that is what we say as what. Earlier days, the chara and water is all available. Now it's not available. Now it's a crime. Like if you know, if the police knows that you are doing this what procedure. So what happens is, he started doing it at home and he refused to reveal this particular story because he thought that it might create more problems. So what happened is, he consumed every day this alcohol which he made with Irumbambuli. And he developed severe renal failure, so we had to dialyze him, and later we did a biopsy. And the biopsy showed exactly what we saw here. These are the case reports from our institution. What I saw the renal biopsy was the case series which we published way back 10 years, almost 10, 12 years back. So that biopsy showed oxalate deposition, severe interstitial inflammation, oxalate nephropathy was our diagnosis. We treated him with dialysis till his urine output improved, renal function improved, a bit of steroids, and this man is back to normal. The second case was a 12-year-old boy. The history is very interesting. This boy goes for tuition to his tuition class. So that house had this particular tree. And he liked the fruit. He started taking every day 1 or 2 while he goes there. So it went on happening on a daily basis. Weeks went, months went, and he kept on consuming this. And that caused this multiple small stones in bilateral kidneys. The diagnosis was quite interesting, and I would like to appreciate this is Dr. Arun's patient. He found out this patient for us, and we managed without a biopsy, nothing. We just asked him to stop this habit. Somehow we found out that he had this habit. So we stopped it and he's back to normal. And this particular patient is a diabetic and hypertensive with a dyslipidemia history which was worrying him so much that he thought that I should get all right at one go. So all of us have got a tendency to, everything should be shortcut. You know, we always love the things happening in a shortcut way. And that's what he took. He didn't want to take the atorvastatin for a long time. So I should get better soon. So he started making juice out of Irumbambuli and started drinking juice every day. So when you take one big glass of juice every day, what happens is the oxalate content is so high, and freshly prepared juice, it's very, very high. And that's what happened with him. We went into severe. This person also had to be dialyzed, and we did a biopsy, and we found the same pathology. And he also recovered. The best part of it, when you stop this taking this fruit, they come back to normal renal function. There is, of course, no chronicity with this. But if you don't know, this particular person might develop because he had an AKI in the history of long-term diabetes. So we are not sure about it. CKD can happen in future. So oxalate nephropathy, just a slide or two, it might be a repetition of what Dr. Sneha and the pathology department has presented. We have a primary and secondary hyperoxaluria. Primary hyperoxaluria is a group of autosomal recessive inherited enzyme deficiencies that leads to increased excretion of urinary oxalate. So what is type 1? There is a reduction of alanine glyoxylate aminotransferase activity in the liver. And type 2 is due to mutation of glyoxylate reductase or D-glycerate dehydrogenase. And this will lead to increased excretion of L-glyceric acid as well as oxalate. Now, secondary hyperoxaluria, already Dr. Sneha has presented, is a repetition, increased dietary intake of oxalate. So, spinach, I think all of us are very aware from childhood onwards, someone who gains strength taking spinach. I feel all of us know. Popeye is a person who always felt that he gets his strength back when he takes spinach. So spinach rhubarb is also a cousin of spinach, looks almost the same. Nuts like almonds and cashews, because I think when you take cashew nuts, we have a tendency to continue eating it. I don't know, I feel it like that. I take 1, 2, 3, 4, it goes on and on. We don't know when to stop it. So this is one. So as Sneha said, that almost 120 grams of cashew nuts at one go can develop this. Then baked potato with skin, soya milk or yogurt, beetroot, then tea, which she already said, green tea. So we have to be careful. Beetroot is also another vegetable. Now, that is because of increased intake of oxalate, which we are not able to, excrete by the kidneys. So why? Because there is a supersaturation, and then it precipitates, then it crystallizes, and then it obstructs. So there is a sequence of events which happen because the kidney is not able to excrete it out because of the huge quantity. Increased production, it can happen because of increased levels of the precursors, glyoxylate, and then because of ingestion of ethylene glycol, and sometimes, less commonly, with ascorbic acid. Now, there is something called enteric hyperoxaluria. Here, basically, the gastrosurgeons would come across fat malabsorption. In these patients, they have fat malabsorption, and this will lead to increased soluble form of oxalate. And what happens is, normally calcium binds to this oxalate and it excretes it out through the GIT. But what happens here, normal calcium here binds to the fatty acids, and calcium is therefore not available for the increased levels of oxalate that comes in. And therefore, it gets absorbed and precipitates in the kidneys. Then treatments like orlistat therapy, surgery, gastric bypass surgery, celiac disease, Crohn's disease, these are all risk factors for developing enteric hyperoxaluria and therefore oxalate nephropathy later. This was the paper which was published, and I could be a part of this case series presentation of Irimbanpuli. It was published in Indian Journal of Nephrology, an index journal. So, are there more villains around? The fear is still continuing. Dr. Sneha has also said about them. This is that fruit. I don't know how many of you have taken this. Any of you would have taken this? Yeah. This is Avaroa carambola. This is star fruit. I know when I was a child, I used to take it because it was available in Assam, because I was born and brought up in Assam, and this is a tree which is very common in almost all houses. And I used to take this star fruit. But the thing is that they have two types, the sweet one and the sour one. The sweet one is good to eat, but the other one is you can't eat it. So this sweet one has got a oxalate content which is actually low compared to that of the sour variety, which has got 7 milligram per gram. So carambola, but it's not much found here. and probably we should be thinking twice about it. Peanuts. I thought peanuts also should be have a tendency to take more of peanuts. And basically, the bodybuilding guys out here, students from our medical college, people take peanuts in large quantities to increase the muscle mass. So probably oxalate content is quite high, and it can cause oxalate nephropathy. Much of case reports are not there, of course. So with these words, I like to conclude that irimbambuli is a traditional ingredient of various South Indian dishes. So it is used in various other Southeast countries such as local remedy, especially in state of Kerala. When used in high concentration, the content of oxalate is high, leading to renal failure because of the crystal deposition in the tubules. Therefore, it's not safe to consume oxalate-containing fruits or whatever food we have described in larger quantities. Let me thank Dr. GC sir today in this Quest program, because whatever we are doing today from the Department of Nephrology is because of the inspiration and continuous support. He never said no to us. And I have a tendency to keep on doing something with informing sir, and sir said, okay, do it. Go ahead. So that was a constant encouragement, and that is how the Department of Nephrology, have grown. And it's almost now 10 years the department has started. It was there from the very beginning when our college or our hospital started. So thank you, GC sir. And I wish to introduce my nephrology team once again in a brief way as to how I think about them. We have Dr. Sneha Anna Joy. A small introduction was given by Annie Thampi. She's a MBBS and MD from CMC Ludhiana, later did her DM in nephrology from Pushpuri Institute of Medical Science. I would consider Dr. Sneha as our lady luck, because she has brought luck to our department. So how is it that is Dr. Sneha? She's a very cool, relaxed, and confident. And for me, like, I always get anxious, I get nervous, I get stressed out, and she brings that cooling element to the department. And what I said, say, like, we in fact we have to rush to get consultations to see, because I have a tendency by ഒരു 12-2 മണിയൊക്കെ ആകുമ്പോഴേക്കും ബാബാ നമുക്ക് പോകാം, അല്ലെ കൺസൾട്ടേഷൻ ഒന്നും കിട്ടത്തില്ല കാണാൻ. And Dr. Sneha would have completed consultations, most of them by the time. She is so fast. So that is one of the greatest thing. But the advantage that once Sneha came over, consultations are so fast, everything is completed by noon time. Our next consultant is Dr. Shamnath. Both of them are here almost for a year time. Dr. Shamnath did his MBBS from Kottayam Medical College, later his MD from MOSC Kolanjeri, and his DRNB from KIMS Trivandrum. Shamnath is actually, when he joined us, I was just thinking, like, Dr. Shamnath should be a gem to our department. Something has to happen through him. Then the thought of interventional nephrology was deep within me, and I said, we should do something about interventional nephrology, because it is not happening anywhere in the state or the country. People are not, with the intervention in the fistulas, because our lifeline is AV fistula, catheters. These are the access for dialysis. Once they are clogged, we don't know what to do. Once they are blocked, we don't know what to do. We start sending them to cardiology team for a cath lab and seeing into the fistulas, or we send to intervention nephrology, radiology. I was thinking, no, this cannot go on for long, because this lifeline of dialysis patients, these patients so known to us, why don't we do something for that? Why don't we take over and take care of these patients? So the thought of intervention nephrology came in, and Dr. Shamnath was very keen on this when I told him. So he is a pioneer behind starting our intervention nephrology. He went for a training to Tamil Nadu and got his training completed. And I think he needs a real applause for starting intervention nephrology in our department. Who is this? This is Dr. Arun Thomas. Everyone is here in this auditorium is definitely aware of his presence in the institution. So what I would say is, I'll just tell him brief about him. He's done his MBBS from Kottayam, MD from Kozhikode, and DM from Trivandrum. And he is a person behind academics, conferences, and any kind of these kind of quest and everything intrigues him so much. He's so interested, and we are not kept at rest. The thing is that he's like, the Greek god. There is Quicksilver. Quicksilver wears a slipper which has wings on it. So Quicksilver cannot land on the ground. He's always a bit above the ground. So that is how Dr. Arun, I always felt, he's flying. And we have to pull him and bring him down to the ground. Come to the ground. So, and he has actually brought in so much of education, workshops, and conferences in our department. And then comes Dr. Geo Philip John. And I have to say a few words about him. Dr. Geo actually done his MBBS from Kottayam, MD from Alleppey, and then DM from Trivandrum. Dr. Geo actually, he brings stability to our department. So he makes the department, because myself and Dr. Arun, we are always a bit, jerky kind of people. So he brings stability. He says, no, this has to happen this way. He's a walking library. And one more thing I would tell about him is, Dr. Geo, when I am not there, I always feel so confident to hand over the department to Dr. Geo. He takes full responsibility and is a pillar to our department, a pillar of strength. And not the least, it's me again. So what I would like to tell about me is, I believe a true leader is a person who creates more leaders and not followers. And I always found leadership in all the people who work with me. They are all excellent, and we try to bring in more strengths to this department. So I would like to wind up with this slide, which is a kind of a powerful supporting powerful slide supporting the department. I would say that we are skilled, but our strengths are different. Our strengths are different, though we are skilled. All fingers are not equal, but these unequal fingers make the hand complete, beautiful and powerful. We are named bird and we fly. Our slogan, teamwork makes the dream work. Thank you.
Thank you, Rajesh sir, for an enlightening talk on Bilimbi. I think a secondary, prior to 2019, prior to COVID-19 pandemic, we had heard more of primary oxaluria and endric oxaluria. So during COVID-19 pandemic and after the COVID post-pandemic, we are hearing more of dietary ingestion of oxalates and also supplement related. When we go back into literature, I think it is because of the high ingestion of antioxidants in food and also as supplements, and also high ingestion of vitamin C that is more related to the oxalate nephropathy that we come across these days. But I think it is pertinent to know that there are such cases, and most of the time the details are missed out in the history. So I think the case is open for discussion.
Thank you very much for this interesting morning and for the information that you've given us. My question is, I can understand eating bilimbi or cashew nuts or nuts and getting oxalate nephropathy. How does hair straightening with the minuscule amount of transdermal spread or absorption affect the kidney? But if you look at the food items, the quantity is large when I speak in terms of the amount, in terms of transdermal absorption. Can you tell us how that happens?
It was seen that a lot of creams also have this creams which we apply for face lightening and all. They also have this glyoxylic acid, but they did not somehow get absorbed so much. So in hair straightening, what they do is they apply the cream and then they use a hot iron to bind the cream to the hair. So that sort of makes the cream go inside. The glyoxylic acid sort of gets into the cell, and that is probably why it has happened more with this.
when you go through the case history, I think most of them had scalp irritation also, which would have increased the permeability, and there will be increased absorption of glyoxylic acid through the dermis. I think in the study in the mice, within 24 hours itself, there was significant absorption of glyoxylic acid, and within 24 hours, there was an increased excretion of oxalate crystals and an increase in the creatinine.
രാജേഷ്, നമ്മുടെ ഈ ഇരുമ്പം പുളി വളരെ റാമ്പൻ്റ് ആയിട്ട് നമ്മളെല്ലാവരും ഉപയോഗിക്കും. അതിൻ്റെ അകത്ത് പണ്ട് നമ്മുടെ ആൾക്കാർ ചെയ്യുമായിരുന്നു, ഉണക്കി മഞ്ഞൾ പൊടിയും ഇരുമ്പം പൊടിയും കൂടെ ഇട്ട് മിക്സ് ചെയ്തിട്ട് ചെറുതായിട്ടൊന്ന് വാട്ടി ഉണക്കി കഴിഞ്ഞ് ദേ വിൽ യൂസ് ഇറ്റ്. അപ്പോൾ അത് ഓക്സിലേറ്റ് ഉണ്ടാവോ ഇല്ലയോ എന്നാണ് എൻ്റെ ക്വസ്റ്റ്യൻ. ഭയങ്കരമായിട്ട് യൂസ് ചെയ്തിരുന്നു. അത് നമ്മൾ എക്സ്പ്ലോർ ചെയ്യേണ്ടിയിരിക്കുന്നു, ഓക്സിലേറ്റ് പോവോ അല്ല. അന്ന് പണ്ട് ചെയ്യുമായിരുന്നല്ലേ? ഗോസ് ഡൗൺ. അത് ഉണങ്ങുമ്പോൾ ഒന്നും കൂടി പോവുമായിരിക്കും അല്ലേ?
Which is fresh ആണെങ്കിലാണ് ഇതിൻ്റെ റിസൾട്ട് സംഭവം.
പറഞ്ഞാൽ കൊച്ചിലെ വരുമ്പോൾ ഞാൻ കഴിച്ചിട്ടുണ്ട് എൻ്റെ അമ്മയുടെ കാവുംഭാഗത്ത്. പക്ഷെ പിന്നെ ഇല്ല, ട്രിവാൻഡ്രത്തെ ആ ഇൻസിഡൻറ്റ് കഴിഞ്ഞിട്ടില്ല. വൺ തിങ് ഈസ് ഐ വാണ്ട് ടു ആസ്ക് ഈസ്, ഒരു ലാബ് റിപ്പോർട്ട് 1 week before serum creatinine was normal and it was 9.3 1 week കഴിഞ്ഞു. Is the lab report wrong or is it an acute onset?
Yeah, it can happen. It's an acute onset. As what happens, the load is so huge that the kidney cannot excrete the oxalate. So what happens is it crystallizes and it obstructs the tubules. So when obstruction happens, patient goes into renal failure. And at the same time, there is also an inflammatory reaction which happens where the interstitium goes into a severe edema. So interstitial edema. These can cause renal failure very fast. Within 3 to 4 days, it can happen.
I am really a patient of you. One thing is, almost all foodstuffs contain oxalate, you said. Yogurt is one thing we are taking for probiotics. Actually, I take 1 glass, especially in the every day. So, how much of this yogurt?
But the content is low. Content is low.
പിന്നെ ഒരു കാര്യം കൂടെ, നിങ്ങളുടെ ടീമിൽ കാണിച്ച 3 പേരും, they are from Kottayam Medical College. We are proud of that. Gio was our student in Kottayam and also in Alleppey. Shamshad was also our student. So both the 3 of us are sitting in front. That is why. Okay. Congratulations to the team and good. I wish all the best for the entire career wherever they go.
Thank you so much. Thank you, madam. Can I just ask you one question at the end of this presentation? Anyone of you will stop from straightening your hairs for the girls? Beautiful girls with beautiful hair.
I think we'll think twice. Maybe.
Anyone will stop?
I don't think that will happen. So my sister used to do the Botox hair straightening, and after telling that, she shifted to another product. So that's a normal mindset, I think.
So they will straighten the hair and drink a lot of water.
Thank you, Department of Nephrology, for an exciting presentation. I personally thank the department for letting me moderate this session. So we have come to the end of the session. Thank you, everybody, for being part of this. So see you in the next session of Quest.